We have seen the functioning of the insulin and how the diabetes is caused by the absolute or the frank absence of the insulin or due to refractory or dysfunction of the receptors of the insulin on the cellular level, especially the adipose tissue and the skeletal muscles. Now, how the insulin is secreted by the beta cells and how the insulin is functioning at cellular level. So, key hormone of the metabolism is the insulin. And it is in the counter regulatory mechanism with the glucagon and epinephrine. So, how the insulin is functioning? It is a large polypeptide made up of 51 amino acids having molecular weight 5808 daltons. So, the insulin is polypeptide, large polypeptide made up of 51 amino acids and it is having the molecular weight of 5808 daltons. On the other hand, when we see the glucagon it is only 29 amino acid polypeptide and the weight is only 2327 daltons. Now, what is the islets of the Langerhans in my next lecture? You have seen in my last lecture. Again, this is the pancreas, the tail, body, neck and the head of the pancreas, and it is having 1 million islets of the Langerhans. The single islet of the Langerhans is having 4 types of cells. It is just like this. This is endocrine gland, so it is richly supplied by the blood. And drained by the veins, which are draining in the portal vein. So, the central core of the islet of the pancreas is made up of the alpha beta cells. These are the insulin secreting beta cells. The peripheral part is having some alpha cells. The beta cells are secreting the insulin, the alpha cells are secreting the other hormone regulating the metabolism of the carbohydrates or the glucose is the glucagon. It is secreting the glucagon. besides the alpha cells and beta cells. On the peripheral part of the islet of the Langerhans, the pancreas is also having delta cells and PP cells. So, it is also having the delta cells and PP cells. Delta cells are secreting somatostatin, and the PP cells are secreting pancreatic polypeptide. PP cells, and these are the delta cells. PP cells are secreting pancreatic polypeptide. It is richly innervated by the sympathetic as well as the parasympathetic nervous system. The sympathetic innervation of the pancreas is coming from the celiac ganglion. Celiac ganglion is having the preganglionic fiber in the intermediolateral column of the thoracic spinal segments, and postganglionic neurons are situated in the celiac ganglion. So, sympathetic innervation is coming from the celiac ganglion, and these nerves are running with the arteries. These are running with the arteries. These are inhibitory to the insulin secretion and decreasing the secretion of the insulin. On other hand, the parasympathetic nerves are this is the ganglion near the islet of the Langerhans, and these are facilitatory and increase the secretion of the insulin. Preganglionic neurons of these parasympathetic innervation are coming from the brain in the vagal trunk, in the anterior and in the posterior vagal trunks. So, these are increasing the secretion of the insulin after taking food. The parasympathetic nervous system come in action, and it will increase the peristaltic movements, it will increase the secretion of the glands, and it will facilitate the food or the chyme to propel forward, and it will also increase the secretion of the insulin from the pancreas to decrease the glucose level of the blood, which is increased after taking food. So, parasympathetic is increasing the insulin secretion, and it is also having some postganglionic neurons which are secreting VIP, vasoactive intestinal polypeptide. It is secreting vasoactive intestinal peptides. This is excitatory for the insulin and increasing the secretion of the insulin, and it is also having neuropeptide Y or neuropeptide gamma. This is inhibitory for the insulin. These are special parasympathetic fiber. So, the beta cells are secreting insulin, and these are regulated by the sympathetic as well as the parasympathetic postganglionic fibers, which are coming from the celiac ganglion and coming from some local ganglion, which are having postganglionic parasympathetic fiber for the beta cells. How the insulin is secreted from the beta cells? I will draw the beta cell here. This is a beta cell and it is having rough endoplasmic reticulum. It is having beaded rough endoplasmic reticulum. It is having ribosomes, so it is rough endoplasmic reticulum, and it is secreting pro insulin. It is secreting the pro insulin. This insulin, after formation in the rough endoplasmic reticulum, is migrating, and during its migration it is converted in proinsulin. So this is the molecule of the proinsulin, and here it is the molecule of the proinsulin. Proinsulin, and this proinsulin is packaged by some vesicles formed by the Golgi apparatus. So these are the Golgi apparatus forming the vesicles, collecting vesicles or Golgi vesicles. Listen again. The insulin is formed in form of proinsulin in the rough endoplasmic reticulum. After formation, the proinsulin is migrating towards the Golgi apparatus to be packaged by the Golgi vesicles. Before packaging, these are converting in the proinsulin. This proinsulin is combination of C peptides and the insulin. This is the combination of the C peptides and the insulin. So this is the beta cell. This is the rough endoplasmic reticulum secreting the proinsulin, and this proinsulin is migrating towards the Golgi apparatus to be packaged in the Golgi vesicles or the secretory granules. And these granules are having proinsulin. These are the Golgi vesicles, or the secretory granules are converting in the Golgi vesicles, and this is the rupture of the Golgi vesicle, and it is secreting the C peptide or the connecting peptide and the insulin in the equimolecular ratio in the blood. As I have told already, this is endocrine gland and it is profusely, it is having profuse or rich blood supply. So, directly it is secreting the C peptide and the insulin in the bloodstream in equimolar ratio. So, C peptide, also known as connecting peptide, insulin, these both are released from the proinsulin. Before proinsulin, it was pre-proinsulin. So, these both are component of the proinsulin. This insulin is having two hormonal component, the mitogenic activating peptide MAP. This is again having two components, mitogen activating peptide MAP. And the other component of this insulin is the phosphatidylinositol kinase. So, this is MAP kinase, mitogen activating peptide kinase. So, this is responsible for the mitogenic activities like cell growth and the genetic representation or the genetic presentation of the cells. And the other component of the insulin is the metabolic, and it is responsible for the entry of the glucose in the cells, the adipose cells and the muscle cells, as well as the conversion of the glucose in the glycogen and in fatty acids and glycerol. So, it is the phosphatidyl inositol. This is phosphatidyl inositol 3 kinase. So, what is happening here? Pre-proinsulin is formed by the rough endoplasmic reticulum. This pre-proinsulin is packaged by the Golgi apparatus and forming the secretory granules, and these granules are forming the secreting vesicles. These are packaging the proinsulin, and this proinsulin is releasing in the blood by forming the C peptide and the insulin in equimolar ratio. Sometimes when these beta cells are overworked, this proinsulin is directly secreting in the blood. After entering in the blood, these molecules, the C peptide and insulin, are separating from each other, and the insulin is having two components, the mitogenic component, which is responsible for the cell growth, and the genetic presenting component, and the other is the metabolic, the phosphatidyl inositol 3 kinase, and both are working for the mitogenic and the metabolic activities. How this insulin is secreted from this beta cell? It is having a little complicated mechanism. How this insulin is secreted from the beta cell? After formation and packaging in the Golgi vesicle or secretory vesicle, the glucose is entering in the cells by some glucose transporter known as GLUT2. By diffusion, when the glucose is entering inside, there is phosphorylation of this glucose molecule, phosphorylation or the activation of this glucose molecule by forming glucose 6 phosphate. It is forming glucose 6 phosphate, and this glucokinase is rate limiting in this chemical reaction. Glucokinase This is the rate limiting enzyme. In this reaction, what is happening here? Glucose is entering in the cell by the diffusion. After entering the cell, the glucokinase comes in action and it will convert the glucose into glucose 6 phosphate, and this is the rate limiting enzyme in this reaction. This glucose 6 phosphate will go in further oxidation, and after further oxidation this glucose 6 phosphate will form ATP. ATP, the energy currency of the cell. So it is the energy currency of the cell. Now, glucose is entering in the cell by diffusion. It is converting in glucose 6 phosphate by phosphorylation by enzyme glucokinase, which is a rate limiting enzyme. This is producing the ATP. ATP are the currency of energy in the cell, and this glucose 6 phosphate after further oxidation forming ATPs. These ATPs are closing ATP sensitive potassium channels. So, I will explain here better. This is again beta cell. This is potassium ATPase gate or ATP sensitive potassium channel. When there is production of ATP inside the cell, this ATP sensitive potassium gate will be closed. This ATP sensitive potassium channel is formed by, it is octamer. It is octamer, and it is having 4 units of the KIR, 6.2 units, and 4 units it is having SUR, 1 units. So it is having 4 units of KIR, 4 units of SUR. These are the SUR units. SUR 2 plus 2, and it is having 4 units of the KIR 6.2. It is KIR 6.2. Now, this potassium sensitive ATP sensitive potassium channel is closed by the production of the ATP, and there is continuous efflux of the potassium outside the cell. Potassium is positive charged, so the inner membrane is negatively charged. In the resting stage, the inner part of the membrane is negatively charged and the outer is positively charged due to continuous efflux of the potassium through these potassium channels. Now what is happening? These channels are closed. These potassium ATP sensitive potassium channels are closed by these ATPs, then the efflux of the potassium is blocked. At the same time, the calcium channels, the voltage gated calcium channels are opened. These are the voltage gated calcium channels. So there is entry of the calcium inside the beta cell, and the efflux of the potassium is blocked due to closure of these ATP sensitive potassium channels. due to production of the ATP by the phosphorylation and oxidation of the glucose molecule in the glucose 6 phosphate and other derivatives. So, there is inner surface is positive and outer is negative. This condition is known as the depolarization of the beta cell. This is the depolarization of the beta cell, and this depolarization, this entry of the calcium and the efflux blockage of the potassium will lead to fusion of the membrane of the vesicle to the cell membrane. This is the fusion. It will allow the fusion of the cell membrane and the vesicle membrane, and there will be degranulation of secretion of the insulin and the C peptide in the bloodstream. So, listen again, it is very simple. At the resting condition, the beta cell is having negatively charged inside and positive outside. It is due to continuous and persistent efflux of the potassium in the extracellular fluid. So, this condition, the inner negative and outer positively charged, is known as the polarization. This condition is resting condition and it is known as polarization. When the ATP production is there due to the phosphorylation of the glucose in the glucose 6 phosphate by the glucokinase, there is production of ATP. These ATPs will block or close the ATP sensitive potassium channels, which is octamer and formed by 4 units of the KIR 6.2 and 4 units of the SUR. These SUR units of the potassium channels are playing key role in the modern treatment of the diabetes mellitus type 2 or the oral hypoglycemic drugs in type 2, especially the sulfonylurea. So, sulfonylurea drugs. There are some medicines which I will talk later in separate lecture on the anti-oral hypoglycemics. These sulfonylurea group of medicines are acting on these SUR receptor of the potassium ATP sensitive channels. These will open these channels and these will increase the secretion of the insulin. So, this is the mechanism of the secretion of the insulin. Now, this insulin with the bloodstream, first of all it is reaching in the liver through the portal vein, and then from the liver to the heart, and it is pumped in the body by the left ventricle. From the left ventricle, this blood, which is insulin rich blood, is pumped in the body. Now, this insulin is acting on mainly the adipose tissue, the adipocytes. And it is also acting on the muscle cells. The adipocytes and muscle cell, the entry of glucose in the adipose cells and muscle cells is purely dependent on the insulin, and about 25% glucose utilization in the body is insulin dependent. and 75% of glucose entry in the cells and utilization is insulin independent. Mainly in the RBCs, the brain, the liver. Liver is having mainly insulin independent, but conversion of the glucose into the glycogen and in the fatty acids is dependent on the insulin. So 25% insulin dependent glucose channels are found in the adipose and the muscle cells. Remaining 75% entry of the glucose in the cells, the body cells, and utilization is insulin independent. So this 25% insulin dependent utilization of the glucose is playing key role in the genesis of the diabetes mellitus. The RBCs are having rudimentary insulin receptors, and the studies on the insulin receptor are done on these rudimentary receptors, because in the initial part of the development of the RBC is having nucleus. This nucleus disappears as the development progresses. So these are having rudimentary receptors on their surface. So at cellular level, what happens? Cellular level, cells are having membrane receptors, membrane spinning receptors. This is typical insulin receptor on adipose cells and muscle cell. It is glycoprotein. It is having 2 alpha units and are known as receptor domain, and it is having 2 beta units which are intracellular. These are catalytic domain. So glycoprotein made up of 2 alpha receptors, 2 alpha units and 2 beta units. Alpha units are outer cellular and are seen on the surface of the cell or cell membrane, and 2 intracellular beta units which are intracellular, and these are catalytic domain. When the insulin molecule appears here, when the polypeptide, insulin is polypeptide 51 amino acid molecule, approaches or comes in contact to these alpha receptor units, there will be phosphorylation of the beta units by the tyrosine kinase enzyme. When the insulin molecule comes in contact to these alpha units, there will be phosphorylation of these beta units by the tyrosine kinase enzyme. It will lead to a series or cascade of events taking place in the cell. There is cascade of events inside the cell, and it will lead to opening of this glycoprotein molecule, the insulin receptor. This is insulin receptor and made up of glycoproteins having 2 alpha and 2 beta units, and it is carried by the GLUT4 glucose transporter 4, and this glycoprotein insulin receptor are playing key role in the entry of the glucose inside the cell. This insulin is opening this receptor, and when this receptor is opened, there is entry of the glucose inside the cell. After the entry of glucose, this insulin will be recycled and it will be destroyed by the lysosomes. And this glucose is entering by these glucose transporter, the glucose transporter 4. So this is the mechanism of the entry of the glucose inside the cell by the insulin. This type of entry is responsible only 25% utilization of the glucose by the muscle cells and the adipose tissue cells. Remaining 75% utilization and entry of the glucose in the body is insulin independent. Some other glucose transporters are responsible in brain are known as GLUT3. So GLUT3 transporters are in the brain. Brain and RBCs can utilize only glucose as fuel. GLUT1 is seen in remaining body cells where the entry of glucose is insulin independent, like the RBCs, hepatocytes, and the intestinal cells. So this was the formation of the insulin, release of the insulin, and the transportation of the insulin in the blood and forming the mitogenic and the metabolic role and entry of the glucose inside the cell by the insulin receptor. This insulin is acting as a key and glucose is transported inside the cell by these GLUT4 or glucose transporter 4 molecules in the cell. What is type 1 diabetes and what is the type 2 diabetes? I will talk in my next lecture.